Greetings and hello to this new series on Inpatient Diabetic Management. This video is provided exclusively for educational purposes and should not be used as a substitute for professional medical advice. So we split this inpatient diabetic management into 5 to 6 chapters. Initially, we discuss about the foundations and initial assessment of inpatient diabetic management. So initially we'll discuss the foundations, assessment goals and harms. Then we'll go to monitoring of how the inpatient diabetic assessment is done, the glucose targets, the capillary blood glucose monitoring frequency, the capillary glucose monitoring use. Then we'll go to the insulin strategy, of which the basal bolus IV insulin and the practical titration. Then we'll go to special situations where how the NPO status is maintained and the insulin therapy for NPO status, steroids, renal failure dose, and for DKA. Then finally, during discharge from the hospital and converting in the insulin to oral regimens or basal bolus regimens or the basal regimens and the follow-up series. We'll split this into basic 5 series with a short video lectures to gain the maximum input in the short period of time. So why management of hyperglycemia matters? Hyperglycemia risks higher infection rates, impaired wound healing. It leads to increased morbidity due to hyperglycemia. A systemic impact is there, longer length of stay and higher risk of ICU transfer or readmission. Treat hyperglycemia even if it is new or secondary to stress. So there is a common misconception that stress hyperglycemia, like once the hyperglycemic value CBG value goes more than 240, that is only once. So you do not treat that. That is a very common misconception. So that also needs treatment. So hypoglycemia risk. In fact, the hypoglycemia is more riskier than hyperglycemia. It has an independent harm of strongly associated with arrhythmias, neurological events like seizures, increased mortality compared to hyperglycemia. Avoid hypoglycemia is a critical as lowering a high blood sugar. Net goal: avoid both extremes. Individualize care based on illness and severity. So immediate actions on admission. When a patient comes to the emergency or the ward, the first know whether it is type 1 or type 2 DM or a new onset hyperglycemia. Always note the recent medications, including SGLT2 inhibitors, steroids, metformins, and everything. Usually, SGLT2 inhibitors are usually withheld during the inpatient admission stay to prevent dehydration, to prevent urinary tract infections and other nosocomial infections that may acquire. And the first test to be done is capillary blood glucose in the emergency or in the wards. If the blood glucose is more than 200 in a non-diabetic patient, then send an HbA1c to confirm whether it is chronic diabetes versus acute stress-induced hyperglycemia. Then look for electrolytes, creatinine and LFTs. The most common abnormality in creatinine occurs commonly in hyperglycemia patients presenting with hyperglycemia. Creatinine elevation can lead to hyperglycemia or hypoglycemia. So ketones, the urine or serum ketones, if glucose is more than 250 or 250 to 300 milligram per deciliter. ABG is done if the patient is acidotic or DKA is suspected. So standardized bundle CBG monitoring. Usually the in-hospital CBG monitoring is done 3 times, 3 meals plus once in bedtime, or Qs 4th hourly, 6th hourly if the patient is in NPO or in enteral feeding. Always monitor hourly in ICU or if the patient is on IV insulin therapy. Always hold HGLT2 inhibitors and metformin in acute illness. There is high risk of acute kidney injury and contrast and instability and also infections. Insulin threshold: if the glucose is more than 300 or ketosis is present, consider starting insulin immediately. Basal bolus or IV. Risk stratification and approach. There are 3 types of risk stratification according to American Diabetology Association. High risk aggressive control you have to do in ICU or critical care settings. So sepsis, DKA, HHS, perioperative major surgeries, high dose steroids, type 1 diabetes mellitus. Moderate risk is usually done in wards and with insulin titration. Type 2 diabetes patients with high HbA1c, ongoing steroid therapy, poor intake, or on multiple oral agents. Low risk or stable, conservative or home medications. Known type 2 DM, well controlled with HbA1c less than 7.5, minor procedures or short stay. You can just continue home oral hypoglycemic agents in hospital also with monitoring. So initial regimen choosing. Critically ill, IV insulin therapy is always preferred in ICU. With hourly glucose monitoring, the target in ICU is strictly 140 to 180 milligram per deciliter, as compared to the ward where it is 100 to 180 milligram per deciliter. So why the range is 140 to 180 in ICU is to prevent hypoglycemia risk in ICU. Non-critically ill in ward patients, hyperglycemia more than 180 milligram per deciliter, we have to start on bolus, basal and bolus regimens or basal plus regimens. Mild or transient hyperglycemic states can be done in conservative management with monitoring. Always avoid sliding scale monotherapy, which is absolutely outdated and not to be used for to prevent better glycemic control, and it also reduces the variability and reactive state. So this is the most important table of this the presentation. Calculating the initial insulin dose, also called the total daily dose of insulin, is based on the patient characteristics. It is not based on the HbA1c, it is not based on the NPO status, it is not based on the procedures or the surgeries that the patient is going to undergo, not based on the infection status in hospital. It is mainly based upon the weight of the patient. So insulin naive patient with mild resistance, the requirement total daily dose of insulin required for the patient is around 0.3 to zero point 0.5 units per kg per day. For elderly and renal impaired patients, it is 0.2 to zero point 0.3 units per kg per day. And for high resistance patient, you can go up to 0.5 to zero point 0.8 units per kg per day. The high resistance is usually contextualized by the presence of high HbA1c, usually more than 9, on steroids, on infections, and obese patients. So Basal-Bolus split strategy is the most commonly followed therapy, which actually mimics the physiological insulin methodology produced in our body by the pancreas. With 50% of basal long-acting and 50% bolus prandial or meal-based is the most ideal method of insulin therapy in hospital. NPO rules: if the patient is in NPO as poor oral intake, give basal plus correctional scale only. Hold scheduled prandial doses to prevent hypoglycemia. So documentation, always order sets, always use structured insulin order sets, basal, prandial plus correction. This significantly reduces medication error. So always you have to instruct the ward staff or the patients or the attenders or the ward doctors to prevent hypoglycemia. Clearly chart instruction for CBG less than 750. If the patient is awake and talking well, give 15 to 20 grams of oral glucose. If unconscious or NPO status, 25 to 50 ml of 50% dextrose is preferred. Always recheck in 15 minutes. So it is also called the rule of 15. 15 grams of oral glucose, recheck in 15 minutes. Consults involve endocrine team if for new insulin starts, recurrent hypoglycemia or type 1 diabetes. So this is the practical one-liner statement for this presentation. Always use CBG pre-meals bar HS. That means 3 times a day, before breakfast, before lunch, before dinner, and at usually at around 10 p.m. Start the basal bolus if persistently above 180. Total daily dose of insulin required is 0.4 to zero point 0.5 units per kg, of which 50% is glargine or long-acting, 50% is rapid-acting divided between the meals. Always remember to hold metformin and SGLT2 inhibitors if the patient is on ward management with ICU stay or with infections or posted for surgery to prevent acute kidney injury, lactic acidosis, and other complications. Hypo protocol, always remember 50% extra IV if less than 70, or if awake, 15 to 20 gram of oral glucose as tolerated. This reference is the American Diabetes Association, Endocrine Society, and RSST Indian Consensus. So always remember HbA1c is the king. Your best determinant between chronic poor control is acute stress hyperglycemia. Never use sliding scale alone as monotherapy, that is outdated. Hold SGLT2 before procedures to prevent euglycemic TKA.